Okay, welcome everyone. My name's Fraser Batty. I'm from the Strategy Unit and I'm going to be the host for this session. So I'm just going to introduce the session briefly and then hand over to Robin Miller, who is going to chair the session. The session is part of the Insight 2020 festival, which is a festival, a 6-week festival of looking at the challenges facing decision makers in health and in social care, and looking at the ways in which the analytical community, the research community can provide insights and guidance and evidence to help decision makers as they address those challenges. As I say, it's running for 6 weeks and we've got very many sessions. If you want more information, you can find it on our website. But today's session is focused very much on social care. And we're going to look at the future of social care in the light of COVID-19 and ask what it means, ask how we should think about social care in that light. We've got a fantastic panel for you. I'm not going to introduce them. I'll ask them to do that themselves as they speak. All I want to do by way of introducing them is just to say thank you to Professor Robin Miller from the University of Birmingham for chairing this session for us. Just a few quick points of housekeeping. Please keep your microphone muted during the session so that we maximise what we get to hear from the panel and minimise ambient noise. If you have questions or you've got a technical issue you'd like to raise, then please use the chat box function. I'd like you all to know that the sessions as part of the festival are being recorded and that we'll be sending links to recordings to people who've registered afterwards. So in effect, please just treat this as a public meeting and make your interjections as such, please. And then finally, I'd like to encourage you to use Twitter to help others hear about the discussion. We've got a hashtag for you, Insight 2020, and also we've put our Strategy Unit account address there too. That's all I wanted to say by way of introducing things, and now I'd like to hand over to Robin, who's going to chair the session for us.
Okay, thank you very much, Fraser, and thanks for the opportunity to chair the discussion today. And I think it's a great sign that we've got a discussion focused primarily on adult social care during the festival. And it's great timing that we've got it today. I don't know if people have seen, but a report was launched by the Women's Budget Group calling for a national social care service to be funded through taxation and other public funds for adult social care. And I'm sure this is a topic that the panelists will be happy to come back to as we go through the discussion this afternoon. So the idea of the structure of the session is quite simple. We're going to throw out 3 very topical questions for our panelists to consider and respond to, and that'll take about half an hour. And then at the end of that, we're going to open up for questions from you as the audience. And so do please keep writing your questions in the chat box, and then we'll present a selection of those to our panelists for further debate and reflection. But first of all, let's please introduce our panel. So Ozzy, would you like just to say a few words about who you are and what you do, etc. would be really helpful.
Okay, hello. Thank you, Robin. My name is Dr. Ozzy Stewart. I use social care services. I'm a wheelchair user and I spinal injury and I've used social care services. And also I used direct payments before they didn't exist from 1983 onwards. And it's very important to realise that a lot of what we do take for granted as government constrained created social care is actually invented and actually campaigned for and actually initiated by disabled people themselves. And I think that's something we need to be keeping in mind. I also am the Sky Social Care Institute of Excellence trustee, and also I'm part of the co-production committee with part of Sky as well. Also, I do a lot of work around Black Lives Matters and other equality matters as well. And Black History Month's come up this month, and I'm rather busy as a result of that. I'll leave it. And also, a final thing is I created and ran for 5 years, that's why I've got some grey hairs to show it, a disability organisation, DPLO, we call them Disabled People's Organisation in Camden Disability Action, which I resigned from quite happily about 2 years ago and let them go off and do what they're doing very well. They're doing very well indeed. So that's me.
Thank you, Ozzy, and thanks for squeezing us in because we know you've got an incredibly busy month just now, so we do so appreciate it. Okay, thank you, Ozzy. So Natasha, do you want to go next for introductions?
Sure. Hi, I'm Natasha Curry, and I'm the Deputy Director of Policy at the Nuffield Trust. And I've been in the sort of health policy think tank research world for about, well, nearly 20 years now. But over the last 4 or 5 years, I have started to lead our social care program, research program. And the focus of the work we've been doing over the last few years is looking at what other countries have done in this space and how they've reformed their social care, to try and see what lessons we might be able to import from those countries. So I'll reflect on some of those international examples maybe.
Fantastic. Thanks, Natasha. And again, thanks ever so much for joining us today.
Thank you.
And David, would you like to go next?
Thanks, Robin. I'm David Watts. I'm currently the Director of Adult Services at City of Wolverhampton Council. I've got a couple of other roles, as many of us do as well. So I lead our regional group on performance and knowledge, and chair the National ADAS work stream around standards, performance and informatics. So I have a real interest in understanding what data tells us and how we use that alongside more qualitative information to help us make good decisions in health and social care. Alongside that, I'm an informal carer. I started out in social care as a frontline care worker, so I have great respect for all our frontline social care workers who've been doing absolutely fantastic work throughout the pandemic period, and be keen to discuss more this afternoon about some of that excellent work that's been going on.
Fantastic. Thanks, David, and thanks again for joining us. And we may be joined by Richard Harling, who is the DAS in Staffordshire and has also got a public health background as well, so he may join the panel in due course. And David nicely takes us on to our first question, which we posed to the panel, which is, what do we think we've learned about social care during the pandemic? And I'm going to pitch that to Ozzy to start off with. Ozzy was a member of the COVID task force and led one of the advisory groups, I think, so he's particularly well placed to make a start for this question. So Ozzy, what do you think we've learned about social care during the pandemic?
I'm glad you mentioned it, Robin, because I actually forgot that was part of that, but absolutely, to say so. But one overriding feeling for me, and I'm talking from a slightly personal, but also I spoke to a lot of people who use social care services, mainly people who self-direct their own care mostly, but not just exclusively for that group of people. And the overwhelming feeling we had was social care suddenly disappeared. It seemed to be broken. It seemed not to meet the needs people had at the time of a major crisis at that time. The narrative was at the time that people have disappeared, there was no communication, no information, no advice, no guidance about what to do, and that advice that did come back was very, very restrictive and didn't reflect the realities that people faced at that particular time around simply trying to remain safe, knowing what to do about employing people if they use self-directed care, or simply to get good advice about safety and getting access to services they felt they needed. So there's a real overwhelming feeling of abandonment that people felt at that time. And also the other thing that people discovered was when we started sharing information, a postcode lottery, some people had a better experience than others. So those are the two overwhelming things I would say straight away that I felt that didn't work well about social care, and those are overriding things. There were some positive things too, and in terms of how people communicated, and also the communities around us, and the word social care suddenly ceased to be just about providing services, but about community, about Sainsbury's shopping. It's about reacting, your local world you're in, peer support, people supporting each other, and also technology. We're talking today virtually. Suddenly technology became a very powerful way to include people, to get advice to people in the way that they can consume it. So I'll stop there, but those are the right.
Okay, no, that's great, Ozzy. So I think some of that's very helpful. In terms of the first point you made was that it wasn't, social care is currently not adequate. That when we got such a crisis, it was shown to be patchy and wanting in places. Also, the fact that there was a postcode lottery, so it wasn't consistent in terms of what people could expect to receive. You talked when your introduction about the fact that you've been so part of the sort of self-directed care movement and people kind of managing their own care and making their own decisions. There was a big emphasis on care homes eventually in the pandemic. Do you think people who have direct payments and who have, manage their own personal budgets, were they equally as recognised? Do you think?
Yeah, I mean, I think as David mentioned, the workforce, PAs, personal assistants, all this. We absolutely not. I mean, I had to remind Skills for Care that the PAs actually had a role to play, and it's a relationship between employer and employee. So there's a real sense that people didn't know how to think about this group of people, or even identify they existed. And even my PAs today don't feel they're part of the social care workforce in the way that, say, a care agency worker or care home would necessarily be so. So it's a very different type of workforce, different world, but it's misunderstood by a lot of people. And certainly when we're talking about all the debates about this, and even local authorities giving guidance and advice, it was totally inappropriate for us as a group of people.
Okay, thank you, Ozzy. David, I'm going to go to you next. Does that echo your experiences, or have you had a slightly different take on things in Wolverhampton?
I think the points that Ozzy makes there are absolutely true. You would certainly find that people will have experienced different responses. If you think about the way that we try to respond within our own city and then work with our regional colleagues, so in the West Midlands there's 14 local authorities, but what you can anticipate is that there were 14 different responses to the way that the pandemic was managed. So absolutely I can understand where that postcode lottery statement comes from. And it's one of those double-edged swords, really, isn't it? So one of the benefits that you have of having 151 local authorities providing local social care and support is that you hope to get local solutions to local challenges that fit the needs of your local communities. Whereas if this was a service delivered at a sort of national perspective, it would very much be on a how do you make the majority fit a service in that way. I think, again, different approaches. I mean, certainly with respect to Care Act easements, I know some local authorities, there were a few in the West Midlands that were named within media of instigating sort of the higher ends of Care Act easements fairly early on in the process. So either reducing down or restricting the types of assessments they were providing, or indeed rationing people's support if there were staff shortages within those particular sectors. I know within my own council that we didn't have to do that. We planned ahead. We did significant amounts of work with our wider council services to really think about how we supported people who may fall into those clinically extremely vulnerable groups or the clinically vulnerable groups. I think if I was going to reflect on what I've learned about social care during the pandemic, is that the role of wider services within the council has a much greater impact to contribute on positive outcomes for people who may be using adult social care services. And whilst you always thought that that was the case, this has been an opportunity to see that in action. So, for example, we knew that we had leisure centres that were closed because of the pandemic, and we were able to redeploy staff into different sorts of roles. So two of the areas which as a council we've been highlighted for with regards to our activity was we put in place something called the Stay Safe Be Kind helpline, and also a food distribution hub. So at a point where we didn't see government stepping into the space of supporting our most clinically vulnerable people with getting food supplies, we were able to very quickly mobilise our volunteer communities, but also our own staff being redeployed into becoming delivery drivers or box packers, or just people who would knock on doors and check that others were okay. But again, I'm very aware that there are significant differences over over the pandemic period, where other local authorities haven't approached it in that way as well. I think the other thing which we've learned about social care during the pandemic, and this is more of a, I suppose, it's a situational thing. So we know that there was a huge emphasis put on discharge from acute hospitals. We've got to clear acute hospitals of people being in, to make sure that we've got sufficient bed capacity to manage ill people throughout the pandemic. But there was a lack of recognition of the role or support that would be needed within the social care sector to manage that influx of people, or indeed to manage some of the infection control activities that needed to be. And you only have to look at some of the information and data to understand just the level of infection that there was sort of between April and early June in the care sector, to realise that actually that was something which was missed at the time, and the relationship between activity that was happening in acute hospitals and the impact on the social care sector had been grossly underestimated.
Yeah, no, thanks, David. No, that's great. And I think for me, I always take it as I don't think anybody in sort of central NHS policy was not, was sort of disregard, was not concerned about residential care and the impact on those residents. They just didn't see it in their immediate kind of sphere of influence, did they? They kind of looked at what they knew, and what they knew was hospitals, and quite rightly they were concerned about hospitals. But again, it's just an example of social care perhaps not being as fully embedded within policymakers' interest as it needs to be. And I think that's what I reflect on that. Natasha, would you agree with that, or do you think that's being a bit harsh?
No, I completely agree with that. What really done is highlight just how complex and fragile the sector is, rather than creating new problems. I think just shone a light on what was already there, and the fact that the system entered the crisis in a crisis of its own. It's been, budget cuts for 10 years or so, workforce shortage in the state in which to respond. And I think the crisis really highlighted just how complex the sector is. I mean, we're talking about of different services, from the big chains to individual care homes, and I think that made the response particularly challenging. So in comparison to, say, the NHS, which has a very centralised command and control structure and clear accountability, the challenges in social care were really different. I think we saw that play out in the PPE distribution, and how providers were struggling to access PPE until that was sort of organised across them. But I totally agree with the points about the invisibility of the sector. But I don't know if anyone was surprised by that. I think that is this just highlighted just how invisible it was. And when we think back to the early days of the response, it was all about the NHS, and it was all about hospitals, as you say. Care homes didn't really feature for a couple of months, and by then it was sort of too late to think through, for that system response to really think through the implications of certain policies. And I think still home care is pretty invisible. I mean, it's cropped up a few times in recent weeks as excess deaths at home. The numbers are coming out and are worrying, but part of the issue here is the poor data in the sector as well. I mean, our knowledge and understanding of the sector is really poor because of the lack of data. And I think one of the other speakers already said the workforce challenges really were visible during the crisis, and I think it's really highlighted just how severe the shortages are, and the fact that we have a very precarious workforce with staff on low pay and poor conditions and insecure contracts, having to work across multiple facilities, and home care workers having to visit 20 people's homes. I mean, the challenge of containing infection in that sort of scenario is really challenging, and obviously on the fact that many people are on 0 hours contracts made them less, not so easy for them to self-isolate at the beginning before testing was more widely rolled out. And I think it won't be a surprise to anyone, but I think the provider sector has been hit quite badly and is showing fragility, but there was fragility there before. We saw providers leaving the market even before COVID, and I wouldn't be surprised if we see more leaving the market as we come out of this wave. And I think my final sort of point was that it really highlighted how important it is to see social care alongside other, as an integral part of other services, especially health, but as I think David said, alongside other sort of community-based services as well, and how important it is we think about how services interact. And I think one of the mistakes that we made in our response is that it was a purely health response in the beginning, and it should have been a more integrated response.
Thanks, Natasha. That's a great kind of overview of a number of issues that were highlighted during the COVID. But my sense was that as time went on, and once we recognised the crisis in care homes, there was a sort of outrage amongst society of just how badly these vulnerable people and their carers have been treated, and almost some degree of solidarity with the kind of social care sector and what they were trying to do and their challenges. Do you think that's fair, Natasha? And if so, do you think that's been maintained as the pandemic has, well, not gone away, but eased slightly over the summer?
Yeah, I think as attention has turned to the care sector, particularly care homes, there has been a sort of outpouring of shock about what's been happening, and a greater awareness of social care in general. And I think, although this has been a terrible period, I think that is quite helpful, because I think the general population's awareness of what social care is and how it works and the problems in the system are really quite poor. I mean, a lot of people think that it's part of the NHS and it's free and, you know, they'll just get it automatically. I think if anything positive can come out of this the last 9 months, is that public awareness of how poor the system is and how badly in need of reform it is. That would be a positive. If that can drive reform, I think this is an opportunity to grasp reform and really bring change about.
Yeah, no, thanks. Ozzy, would you agree? Do you think there's a kind of a chance here to build something positive from the terrible experiences of COVID? And if so, would it be that kind of sort of wave of outrage and commitment to doing something, or have you seen other kind of green shoots that from the crisis?
Yeah, from my perspective, I don't see the outrage so much, because that was directed towards the home care side of it and the deaths, the excess deaths, etc. Where I saw the positives in terms of public awareness is around the fact that there were people who were in need of support in the community that people knew and were aware that they were isolated and needed their support. And I mean, I'm just thinking about in the area I live in, Camden, Brent, Harrow, which I've done my sort of intelligence around those areas. There's been a really positive response from lots of people about organising volunteering to make sure people are okay, safe, or going shopping, etc., etc., which surprised me to the degree that was. It wasn't your yummy mummies from Hampstead as well, because I thought my cynical Hatsons on here that would be doing this. It was actually local people who were in the same situations that other people were in, but checking on people and wanting to help in some way. Capturing that and building on that is another question, because it has subsided to a certain degree in my areas, of course, but there's still a great awareness that there are people in the community that do need that sort of support. But where I do see it is what I really liked was the fact that there was also a sense that your local shops or other businesses had a responsibility to make sure that people were safe as well, and people expected that. And I think there's now a greater expectation of that wider community, and I'm talking about commercial, residential, and also if you think about gyms, shops, game centres, whatever, that are aware that they have a wider responsibility, a moral responsibility to make sure that people can access their services and like everybody else, or actually are checked upon in lots of ways. I just quickly tell you a story. I know this is go back before COVID in Marks and Spencer. I was in Marks and Spencer's once, and there's an older woman there. She spent quite a long time talking to the checkout lady. And when I got to I got after her, she turned to me and goes, "Do you realise that woman doesn't speak to anybody? I'm the only person she'll probably speak to today. She's very lonely, and she comes into the shop just to get human contact." And the shop's Sainsbury's is aware of that, so they facilitate that in some way. So they allow her to get that human contact she needs. They're aware that she is an isolated person, and shopping is the only way she meets people. So there is this greater sense that I think people are becoming more conscious of that our wider community has responsibility about this too. And I want that to be part of the debate. And I don't think it has been as firmly. I think we've tentatively talked about it, but not said, actually, this should be an obligation that we have, or we should be conscious of and aware of, that we should be playing this role.
Oh, thanks, Liz. That's really helpful. So it's almost like a recognition of a broader social need, which is there, and which social care services, traditional social care services, can respond to some degree, but actually it's not enough. It has to be more of a community involvement and individual contribution. David, how do we build? That reflects in part, I think, what you were talking about in Wolverhampton in terms of different agencies and different services contributing to try and to support people. How do we keep that momentum going then? How do we build on that?
So I think there have been really important points made so far. I think part of my concern is, whilst social care is in the general public psyche at the moment, you still don't see the movements from policymakers around actually grabbing that nettle and dealing with it as an issue. You can still see it getting pushed back into the future and being put in that too difficult to do box, which I certainly don't feel it is. I'm also of the same mind of Ozzy, in that one bit which I'm really concerned about is that we lose all of this community building capacity that we've seen really stepping in because they felt, we're in a crisis, let's step in. And how do you turn that into being about, well, we don't just want community organising whilst we're in crisis. How do we generate a positive feel about it so that actually more and more people want to be involved in that? One thing which we've always struggled with is people saying, I don't want to volunteer because I can't commit to doing it on a regular basis. And I think everything that we've seen throughout the pandemic around people getting involved shows that actually you don't need to do it on a regular basis. The more the merrier. And if you can only help out once a month, that's absolutely fine, because there's another 20 people who can only help out once a month. And I think it's, I think I always have to be very careful, because it's really enticing for local authorities to step in and say, wasn't this fantastic? How do you do more of that? And in some respects, what we have to do is step away a little bit and create the space for some of these really good initiatives, some of these really good relationships that have been built, to give them the space to grow and become even stronger in that sense, but be there to provide support, be that financial support or support in kind that can be provided through local government to assist with that. But if you look back over the history of social care, if you think of the late 90s, early 2000s, when there was money in that space, what did we do? We stepped into space where communities were strong, where the voluntary sector was strong, and took over that and turned some of that into statutory services in that sense. And I think what this has really demonstrated to me is that actually there is such a strong need for strong communities, for good neighbourliness, for people keeping an eye out for each other. And being a child of the 80s, I can remember walking up the street and walking into my mate's house because the door was unlocked. I don't think we'll ever get back to that, but if you can generate some of that community feel that has been generated over the past 6 months or so, celebrate it. Really point out why it's been so effective and why we just need more of that. I think it's got to be done on more of a movement basis rather than how do we build it in, how do we contract for it, because it will never succeed if we do it that way.
Thanks, David. And do you think local authorities, because they still are the bodies, aren't they, that have got their kind of responsibility to facilitate those development communities, do they have the skills to do that currently, or do you think that's a gap that we need to kind of foster?
There's fantastic people in every city, every organisation in that sense. So even within my own local authority, we've got fantastic people who would be really good at brokering and facilitating conversations and knowing when's the right time to step away. The problem is they're trying to do 3 people's jobs at the moment. So these things, you know, building community, creating the space for community isn't done in a half-hour meeting or a 2-hour workshop. It's built up over hours, days, weeks of people coming together and talking about the challenges which are being experienced locally, and then deciding which are going to be addressed, and how we're going to address them. But within every city there will be thousands of people who can absolutely help with this sort of approach. It's more about how do you provide the right sort of support, just enough support, so that it feels like you're not trying to take over as a statutory organisation.
Yeah,
Can I quickly add one thing? The safeguarding concept needs to be managed properly as well, because one thing local authorities tend to do is say, oh my God, that's too risky. These people are strangers, they'll help that person. When actually risk is maybe a necessary part of this process. We can't give those people the space without accepting that there's going to be a degree of risk with that. I'll stop there.
Well, that's great, Ozzy. That's great. Fantastic. Yes. So, Natasha, so we've heard from David that we need to build communities, from Ozzy that we need to be less risk averse. So this moves on to the final question, I think, which is about what would you advise the Care Minister? And probably Natasha, in her role in Nuffield Trust, is advising the Care Minister. So we'll just put that out there. What else would you add to that, Natasha?
So not quite, just on that last point of communities, or building communities, I think that is really important. I think we need to think about the voluntary sector and how to strengthen that, because obviously they've taken a really big hit over the last year and before with financial pressures. When we're thinking about, so in my job at the Nuffield Trust is to think about system reform at a high level, and when we've been looking at the international examples, so mainly Germany and Japan, of how they brought about reform, I think it's interesting that they've started the conversation in a different place to where we start our conversation. So if you look back at the history of proposals for reform in England over the last 20 years, we always start with how can we fund it? Who's going to pay? And it kind of frames it quite negatively. It's all about money, and it's quite difficult to sell to people and to garner support because of the misunderstanding around whether social care is free in the first place, and it becomes quite politically toxic quite quickly. When you look at reform in Germany and Japan, they started with the vision. What is it that we want as a society? What sort of system do we want for ourselves, our family members, each other? And that's the starting point, and that's how they managed to build public support and political support. And once you've got that, then you can start the conversations about, well, how do we pay for this, and who should pay? So I think if I was giving advice to ministers, and I do try in my various conversations, is to start with that vision. What is it that we want to achieve? And then once we've got that broad vision about the shape of the system, the principles we want to fulfill, then we can think about how do we fund this, and then to make some clear decisions about funding that are fair and clear and understandable to the public, so that people understand what they're paying for, and then to have clarity and consistency about what they're going to be eligible for as well. So as we heard a bit earlier in the conversation, one of the problems in the system at the moment is that local variation. What you can access really varies between local authorities. So I think, and I think that creates a sense of unfairness and distrust. So I think we need to move to a clear funding system and a clear eligibility framework, so that people know what they're entitled to and they can plan. And then the other part of reform, I think, alongside the funding and the eligibility, needs to be how are we going to stabilise the provider side of this? And by that I mean the organisations providing care and the workforce. And I think that needs to be a fundamental part of the thinking around the shape of services, too often sort of forgotten about, I think.
Fantastic, great. So Ozzy, would you agree? So we've got developing a vision, we've got a fairness to access services, and we've got a stability of the provider side. Would those be your top 3 recommendations to the Care Minister?
The fourth one I'd add is the voice of people who use their services and the types of ambitions they have for what it is. The thing that frustrates me most about social care is perception that we are recipients of care and not citizens and participants too. So there would be an element there would be about how you have those conversations with different groups of people. How do you enhance choice, not too much choice and control, but how much you might enhance citizenship? And to me, citizenship means choice, control, and responsibility. Add that word on me and there about living a good life and or having a good death if it's end of life. It's about those sorts of things, and that's where I think to Natasha's point about what's our vision. The vision has to be part of those people who have that lived experience of having that vision about their lives, what they want to. I don't necessarily think people just want to be put in a box and put in a warehouse, and they use those places and to be to be left to be cared for. I think they want to have meaning to their lives.
And do you think, Ozzy, because obviously you've been a part of the of such a movement for a very long time, and there are things like the Think Local Act Personal, which is a national network in England. We've got things like Social Care Futures, which is just sort of a more of a sort of campaigning social movement type body. Do you think we have the vision, but what we haven't got is we haven't got political endorsement and engagement of that? Or is it a question that we've got part of the vision, but actually there's still quite a lot of work to be done?
I think it's a little bit of both, because my world I come from in terms of the Black community and things like that, they're not part of the discussion at all. So there is a question mark about who's shaping this vision and who's having those conversations. So I think part of the vision's there, but it's not complete. And I think there needs to be a wider discussion about what it means to be living as a citizen in Britain, and then how we can reflect that in social care. But also I do think there's a legitimacy bit here about the voice of people who use those services, and the equality, the lack of equality about the weight of those voices versus other people in this space as well. So I do think there's work to be done in terms of having an acceptance. We have to have a conversation in those ways, but also an acceptance. It's not seen as a threat, but also a value to the discussion too.
Yeah, thanks, Ozzy. And David, whose responsibility is it then? Local government has responsibility for adult social care services, as you said. We've got a different response depending on the local area and the different traditions in that local area. Is it Director of Adult Social Services and the National Association? Should they have a lead responsibility for deciding this vision, or should it be decided in Westminster? Who should be leading it?
Personally, I don't think any of those should be leading it. I think ultimately it should be our citizens that are leading those discussions. And I don't think that we do that well, particularly when we're having national conversations around the way that support may be provided. How do you co-produce a vision at a national scale is something that would be extremely challenging in that sense. I feel a bit hard done by, Robin, because you haven't given me my opportunity to say what would be the 3 priorities for
David, what would you say were the 3 priorities to the Care Minister?
So other than those that have been mentioned, and actually market stability is one of those which would be top of mind, although I'd probably go into a little bit more detail in saying that actually I think there needs to be a conversation with the provider sector as well about how they need to transform and change to meet the changing expectations of people that may have needs that are currently being met through that route. One bit which hasn't been mentioned is the role of informal carers, and just how our informal carers responded over the last 6 months when services have been closed, or it's been unclear about whether, for example, a day service could be open or had to be closed, or whether respite services were running or not. Our informal carers have once again stepped up and said, I will look after my loved one. I don't want my loved one to be going into this setting. I want to support them there. But actually, over that whole period, where has been the shift in resource to support those people? Now, it's partly been supported by things like family members being furloughed, therefore still receiving pay, but being able to do additional caring responsibilities within that. That means that they're no longer going to be there unless you find a way of recognising that actually that informal care support is hugely required to sustain services and actually manage the demand that we've got moving forward. On the market stability element, one of the bits which it will sound really odd, but when the NHS 1% cap was lifted, I was one of those people that had my head in my hands, because immediately I could see that there would be an exodus of nursing staff from nursing care homes, because we were unable to uplift the pay band for qualified nurses who are required to oversee that activity. Not that I in any way begrudged our fantastic NHS staff a well-earned pay increase. It's just I could understand the impacts of that. And earlier on I mentioned about the impact of discharge from hospital and how disproportionately that affected local authority. Again, if you don't have parity of salary for nursing staff in the social care sector, or for PAs, or for unqualified care staff to nursing auxiliaries or care staff within a hospital setting, how are you going to compete? And in fact, I can't even compete with Lidl or Aldi at the moment on what they're paying their staff. So attracting and keeping people in the sector is a huge challenge at the moment. I think the question which you did ask me, Robin, was very much around who needs to lead this, and I think it is, how do you create that space for a vision to be co-produced? But I still am slightly cynical about whether it will be. We will move. Will I see it in this Parliament? Discuss. Have I seen it in the last 3 or 4 parliaments? Discuss. Until we can have a conversation which is actually whoever's in power needs to be behind this as an initiative. We need to reform adult social care. It needs to be citizen-led in the way that we design and take that forward. Unless you can get cross-party sign-up, you're never going to go beyond the period of the current Parliament with any transformation that you can do. And that's one of the huge challenges that we have, Robin. And that's where you need that really grown-up, this isn't a political conversation, this is what do we want for our society, what do we want for our citizens, what sort of first world country do we want to be?
Oh, thank you, David. And so Natasha, so in Japan and Germany, where they have managed to achieve social care reform, what was it that got them over the starting line that we've seen so hard to, we do reviews and we have, reports and we have debates, but we never seem to take it forward. But what did they do that actually enabled them to move beyond that and to set this vision and to start to make it happen?
I think there's a couple of things that are different to where we are. So there was a groundswell of public support for change. So there was, I think, for whatever reason, I haven't managed to understand it, a greater pressure from the public for change, so a greater awareness of what the problems were. So the reform of social care tipped from being sort of politically toxic, like it is here, to being a vote winner. And so the parties were then incentivized to come together and put forward reform. I mean, Germany, I think it was easier there because it has a history of coalitions, and so they're used to that sort of more collaborative style of government. But in Japan, I think it was mainly the pressure from the public, the kind of the burden of care that fell on families solely. They didn't really have much of a provider market at all. And was in both countries, it's interesting that there was a sort of either political or economic crisis that kind of opened up a window for the conversation to change. So in Germany, it was reunification, and that ushered in a different conversation and the need to discuss a whole load of social policy issues that hadn't really been on the table before. And in Japan, the economic crash of the early 90s left its economy very fragile, and they really needed, and because of its demographic pressures and its shrinking working age population, there was a real drive to get women into the workplace, and so free them up from informal care, and to create a provider market to try and stimulate the economy that way. And then the other thing that I think is different, which links to what we were just talking about, was in Germany in particular, there was a political leader, there was a political face to this. There was an individual politician who campaigned for this, who was trusted across all political parties, and he managed to kind of push forward that and hold the conversation. And I don't think we have that one individual driving this and leading that. And so I think that's kind of where things are a bit different here.
Yeah, no, that's really helpful. So we're already running out of time, very sadly. So I'm going to move us on, just responding to some of the questions in the chat. And a couple of questions have come up about the health social care relationship. And we talked a bit earlier about the fact that there was such an emphasis on hospitals to the detriment of care homes, and more importantly, people who live in care homes and also people in the community. But also there's been some discussions in the chat about health and social care professionals working together. So recognising the huge contribution that frontline care staff make, and also thinking about a parity between health and social care professionals. What do you think, Ozzy, about that? Do you think there's still a sort of differential in the kind of way that we see health professionals and social care practitioners or professionals?
As my sister is a doctor working in a hospital in Witney this moment, as I speak at this moment, I see there's a massive difference between the way we understand or think about, even social care professionals, health and social care professionals think about themselves in terms of this as well. And what I find very frustrating is a lack of seamlessness when we move from one to the other. I had a very unfortunate incident where I needed to be hospitalised about 2 years ago, and I was interested to watch this because I wanted to see how it worked in terms of where social care finished and where health and social and the health bit kicked in, and then reversing going out. Now we're very knowledgeable, so we're able to put things in place for me going in, coming out pretty quickly. But I was wondering, if you couldn't do that and whatever, what would happen? And one thing was that one person who works as a social worker in a health hospital, I asked them about when people leave the hospital, how does that work? And he said, well, actually it doesn't work. It depends on the individual, depends on their family, depends on circumstances. He said there's a method you need to understand to get out of hospital in a good way. But a lot of people don't understand this, and a lot of health professionals don't either. And so there's a real disconnect between the two worlds in that sense. You feel that as well. And also, I mentioned personal individual budgets, are they called, or the direct payment budgets. In Camden, which I'm in at the moment, did I say Camden? I probably did. There was a year or so ago an unholy row about who pays and who should, when a personal budget stops and when a personal health budget starts. And in the end, the experiment of having people with one part of being a direct payment and one part of personal health budget fell apart because the CCG and the local authority couldn't agree on how this should work. So even on the finance side, there are real problems. I think we're putting our finger on a big problem when we talk about relationships between health and social care, in terms of the workforce, in terms of the knowledge base, in terms of lack of seamlessness, let's put it that way, of the working in that way. There seems to be a big difference between the two worlds.
Thanks, Ozzy. And David, is that your kind of experience as well? That we've still got, it was way back in the New Labour time that we had the Berlin Wall described as being the gap between health and social care. I was never quite sure who was East Germany and who was West Germany, but anyway, we had the Berlin Wall in place. Is that still in Wolverhampton? Is that wall still, built and dividing things up, or have you started to see some chinks emerging?
So I guess we're fairly lucky in Wolverhampton. You've got a local authority that is has the same boundaries as the CCG, has one acute trust there, so it's really possible to build strong relationships up. That aside, you still have challenges from centrally organised services, so for example NHS England, NHS Improvement, and their push for different indicators and different outcomes to be achieved. I think there's always going to be a difference between social care and health, and whilst you would expect value bases to be very similar, actually there's some quite stark differences. So when you think about healthcare, it's often professionally led. We are the experts, we know how to fix your health problem. In social care, you are trying to, well, hopefully in most social care settings, you are trying to rebalance that power. The individual is the expert in what works for them, and you're trying to connect them in the right way to things that work with them, and you have to cede power. And whilst you've got that statutory responsibility to make sure that needs are being met, I absolutely agree with Ozzy. You need to be prepared to take positive risks. we're starting to see challenges coming out now around restrictions in care home visiting, around people saying, but actually, I would rather die of COVID than not see my family for the next however many weeks. And so there's these value bases, these ethical bases which need addressing, and need opening up for more open discussion to say, well, how do we deal with these sorts of scenarios in those settings? But I think ultimately it's that power imbalance within the NHS. You've got that expert first, we will fix the medical problem, I employ occupational therapists, and they work very differently to the occupational therapists which are employed on the ward, who are often saying this will be problematic, you need to meet that need, whereas my occupational therapists are saying, but you don't necessarily have to meet that need in that way. Someone can, learn that skill themselves, or they can use a piece of equipment. You don't need to be putting care in to support that. So there is despite them being very closely aligned, they are sort of apples and pears in that sense. They have slightly different value bases, slightly different approaches. Neither of them wrong, but they're just coming at things from a different perspective. Because certainly if I had cancer, I wouldn't want to say, well, I'm the expert in my condition, I want to fix it. I want a consultant oncologist to design my support and my treatment plan. But when it comes to how I live my life 365 days of the year, I want to make that decision, and that's what I try and instill in my workforce about, yes, you may know how to connect people to the right things, but ultimately they know what the right things are for them.
Thanks, David. So Natasha, would you agree? We still got this kind of just basic difference in worldview or values between health and social care that acts as a stumbling block to us collaborating more creatively?
Yeah, that was a really, really interesting analysis of the situation. And yes, I would agree. And I think when we look back over how many years we've been trying to integrate health and social care, the places where they've had most success, it seems to be where the relationships have been good and where there's a shared culture. And that seems to be based on more of a sort of history of relationships rather than any sort of policy mandate. And that's what makes this really difficult to scale and spread. And so some of the dynamics that David and Ozzy have talked about, that in that power imbalance, is also embedded in the system with the money, the dynamics of the money. You've got one system that's fully funded and relatively well funded in the NHS, and then you've got the other system which has been just seeing cuts year on year. And so you're asking those systems to work together, and there's just that inbuilt tension. So I think if the relationships are not good, then those mechanisms that underpin the system just exacerbate those poor relationships. I mean, we do have an opportunity now with the creation of ICSs and PCNs, primary care networks, and integrated care systems, which theoretically should facilitate some of this stuff. But I think those sort of cultural and relationship barriers will persist, and it will take time to make progress.
So David, what's your comment on primary care networks then? Do you think because obviously we've got general practice, frontline, very much kind of a horizontal integration with social care. Do you think that's going to be the body that's going to enable us to work better?
So again, look at where integrated care systems are being driven from. They've always been driven from central NHS in that sense. And the original drivers, whether anyone wants to fess up and own up to that, has been about delivering significant financial savings within the NHS. So they started out as sustainable transformation partnerships, or as they got known as sustainable hospital partnerships, because that's ultimately the size of hole which each ICS was trying to fill, was a 400 to 500 million gap, which they were expected to deliver around that. But so the difference that you have with an ICS is on a much bigger geographical footprint. So for me, it's the Black Country and West Birmingham. So it will be a population of over 1 million people. A PCN, a primary care network, is a population of 50 to 70,000, something like that. So I can do business with that. and I can do business in a targeted way. So those GP practices will serve certain wards within my city as part of a primary care network, or at least you think they would, because sometimes primary care networks aren't built on geography, they're built on which GP practices want to work with which GP practice. But if they are built on geography, or if they are built on focusing on the particular challenges within those wards, you can start targeting some of the interventions, and particularly the public health interventions that you have in those areas. So if I work with a PCN that is primarily supporting 2 or 3 wards in our city that are in the 10% most deprived wards in the country, our public health approaches would be very different to working with a PCN that supports the more affluent wards in our city, where perhaps there's an older population and it's about managing ill health in older age in that sense. But I think the model of PCNs has great potential. And if you use the model of PCNs and you focus on that, you will build up to have a good city or local area approach, which then, if each of the respective areas that contribute to the ICS will make a strong ICS. If it's an ICS that has been built from top down, we want to commission at scale and do X, Y, and Z. You're approaching it from the wrong direction. You need to build local and then build up from there, and then influence what is the remaining bit that gets delivered by the integrated care system, which should be high-end, low numbers, specialised commissioning in that sense. That's what you would hope to see primarily being commissioned at that level.
Thanks. So again, a call for building up from communities with communities, and then building up to the kind of higher level beyond that. Ozzy, one last minute. I'm going to give the last comment to you. Anything you'd like to add to that discussion, and I'll hand back to Fraser to kind of wind things up.
Yeah, I'll just simply say briefly about this, saying what I would love to see in health and social care is a seamless journey that individuals don't notice the difference. They go from one to another with people the same value based, focusing on the individual being the one who's in control, but being supported to make decisions informed in where they need to do so. We're nowhere near that yet, but I plead for that but the values based being more of a social care approach.
Thanks, Ozzy. Great, and that's a great final comment, I think, from the panel. Fraser, over to you. 1 minute to go.
I don't know, I can do it in a minute. Look, I love that discussion. That was brilliant. It ranged between, the politics of things, the data of things, frontline operation, the future, the past. I really love that conversation. So on behalf of everyone who's attended, on behalf of the strategy, I want to say thank you very much to Ozzy, David, Natasha, and also Robin for chairing. That was fabulous. The final thing I just wanted to do was just to tell you a couple of things that are coming up in the programme. Later on, can you see this? Robin, can you see?
Yep.
On Thursday, we have a session which our partners Ipsos Mori are leading, which will build on a lot of the conversation from today about how to better integrate citizen and population involvement in decision making. That promises to be great. And then on Friday, we're going to be reflecting on our experience as part of the analytical collaboration, which was between the Strategy Unit, Nuffield Trust, Health Foundation, King's Fund and others, where we attempted to pool analytical expertise and coordinate it and look at some of the big questions that came out of the COVID crisis. We'll be sharing lessons on that. So I encourage everyone to register. The URL for people to do so is there. I think that was inside a minute, Robin. What do you think? That was nice.
I think that was pretty good. Yeah.
So listen, thank you ever so much, everyone. I don't know how we express thanks now we're all at home at the end of a Zoom call, but if we could all say thank you very much, maybe clap at home or something. Thank you to the panel. Thank you.
Right.